All right. So, what I want to talk to you guys about tonight is I get text messages all the time. Hey, how's this case? How did I do? Um, and I often see that people are not exactly following the prescription and the protocol and a lot of the key principles that I talk about in our lectures at the just the cadaver course. And so I really wanted to showcase some of the x-rays that people have sent, and I really wanted to showcase some of the x-rays that I see online, give those a critique, highlight some of my complications, and I wanted to just give a brief update with some of the new neonatal products that I'm using that I think have really kind of changed what I do on a daily basis. So, just as you guys know, a little bit about me. I have two offices in Fort Worth and Amarillo. To date, completed over 2,700 fixed All-on-X arches. We're roughly completed about $70 million in implant dentistry over the past 13 years in practice. All of our cases, everybody's getting pterygoids. We do zygomatics, several zygomatic cases on a monthly basis. We will do transsinus, a few transnasals. They don't present themselves very often. Most of the time, what has really changed in my practice lately is the amount of angled abutments that I use. So basically, every implant is angled. We're angling towards the nasal crest. We're angling anteriorly with our middle implant. We're angling posteriorly, superiorly with our pterygoid implant. And so it is very common that for a upper maxilla, for me to use 6 30-degree abutments or, you know, 4 17s and 2 30s. And that actually gives us more angles, more. I can get a much thinner prosthesis because I can really, whenever you angle the implant, I can get a 1, 2, 3, 4, 5 degree change in the implant timing, versus if it's straight, like in the maxillary anterior. If it's axially, then I really only have two options, right? I have a 0 degree or a straight, and then I've got a 17 degree. So by angling those and then using by angling those toward the nasal crest and then using an angled abutment, I can change the timing 1, 2, 3 degrees and really get a very narrow prosthesis, get the screw channels very ideal. So that's been a change. And you can see this is what I'm presenting on the screen right now. This is a case prior to 2018-19 is when we really started hitting the pterygoids heavy. As you can see, these are Neodent GM implants. So this is late 18, sometime in 19. And it's an older methodology where the anterior implants are straight and axial. That works if that's what you're doing, but I have changed my practice now to where most everything is nowadays is nasal crest. And with that nasal crest, we are able to really get some great screw channels. So what I want to talk about tonight is review key concepts in full arch, review the AOX protocol, and then give you guys updates, and then go over some complications. So I need to let somebody in, apparently. Give me 1 second here. Okay, good. All right. Okay, so now let's go back to our PowerPoint. All right. So as you guys know, All-on-X is a systematic protocol utilizing 4 to 6 implants, and nowadays every one of my arches is 6. It's not the number that matters, it's the placement. So we are not doing 6 implants anterior to the sinus. We're doing 4 implants anterior to the sinus, 2 implants posterior to the sinus. You have to immediate load these cases. You have to immediately place, teeth out, implants in, and then give them a same-day provisional. If you are not doing that, if you're not doing any of those steps, you are not practicing all on X. And this is where patients get really confused in the marketplace, because they can go to, say, another clinic that's cheaper, and they can get 4 implants, but they're getting a snap-on, as we all know, and the fees of that $7,500, $5,000, and it's just really confusing. These patients don't understand what they're not getting. And so it's very important that if we are a all-on-X provider, we need to be making sure that we are doing immediate placement, immediate load, and immediate provisionalization. And the key to immediate load and immediate provisionalization is stability, but it's also following the key concepts, which we'll talk about later on tonight. So, what are the benefits of full arch? We are able to do one procedure in one day. Patients are able to get an improvement in their diet, improve self-confidence, and guess what? No more dentures, no more sore spots. Our patients are here for so much less time than replacing teeth traditionally with partials, cast partials, valplas, all of that. Snap-ins, so much of a limited maintenance with all on X compared to snap-ins. And so it is just a much better way to replace teeth, and it allows us to really serve our patients better. We are able, if you look at this girl in the very middle of the picture, she's needing orthognathic surgery, but she also needs orthodontics, and no orthodontist is going to put braces on a rampant caries patient with severe periodontal disease. So we were able to treat tooth decay, periodontal disease, occlusal relationship, and orthodontia, and do a bimaxillary intrusion over maxilla, not impacting the maxilla, but reducing it. And so we were able to give this patient exactly what she wanted with one procedure, one day, so much cost effectiveness for her, and it's just increases our predictability, increases our patient happiness, and it is ultimately serving our patients better, because these patients don't want a removable option, and they want predictable results. And that is the beauty when you execute. And this is what these patients expect. And so if you are going to jump in and be an all-on-X provider, you have to execute every time. Failure to execute is going to lead to board complaints, is going to lead to legal issues, is going to lead to unhappy patients, a non-profitable practice. I've heard of a center in America that has roughly a 70% prosthetic remake rate. I mean, those patients are going to be, very angry. Imagine 3/4 of your patients are remakes. That is just a recipe for disaster. And so we have to execute, and we have to understand the cookbook recipe so that we can execute. And there is a huge wave of patients needing this treatment. The demographics are shifting in our favor. These patients are getting older. They have had, dentistry that has failed them, and they all have friends that have gotten this done. And so it's, when you have a patient in need, there's not a lot of lifting that has to be done on these patients. It's already been done for us by the marketplace and by their friends. And so just remember, where are all of these thousands of patients that need all on X? Many of them are in your offices. And they are there because there's been a lack of treatment options given to the patient. The patient that you see here to the right, she came to us for a broken valplast. And we could have simply just said, hey, Susan, we can give you a brand new Valplast and, put you on your way. But we stopped and we said, are you being served by this removable partial? And she said, absolutely not. And we said, guess what? We have a better option for you. And here she is. She got her upper done, and then 2 years later came back and she got her lower done. And so that takes a Valplast repair, which in my office, that's, a couple $1,000s. And then now this is a $48,000 case. Also, lack of comprehensive treatment plans. If you are diagnosing single tooth dentistry, you are going to miss all of the All-on-X patients because you are going to be focusing on one tooth. Focus on the patient, focus on their lifestyle, focus on the benefits. And guess what? When you do that, you will create more predictable treatment plans. You will create treatment plans that serve our patients, and you will create happier patients, and you will be able to get beautiful results because everything is going to match, everything is going to be done at once. So these are the results that we can give our patients. And again, this is a guy that came to see me from Arkansas. He was being treated with a removable partial denture. Sure, his lower teeth, as you can see, are not restorable at all. But here we had 4 perfectly healthy teeth. We sacrificed them for the greater good of the patient. What are 4 perfectly healthy teeth going to do for him? We cannot build a house, we cannot build a foundation around these existing teeth. They're malpositioned. And guess what? It's actually going to cost him more keeping his teeth. And then what happens when those teeth fail? Now it's another $25,000, and doing this single tooth or single implant is going to cost him double. And so, we got to listen to our patients at consultation because we're treating more than just teeth. And look at this beautiful end result. Beautiful porcelain, beautiful ceramics. This is what he was after. And by listening to our patients, which we all know, but getting over, hey, we may have to sacrifice 1 or 2 or 3 healthy teeth for the greater good of the patient. Now, I'm not saying we need to extract all healthy teeth. No, there are definitely some indications where it would be wise to save them. However, we need to be thinking comprehensively. So, we need to treat more patients better because more patients want fixed, and we know that fixed is better over most traditional means at handling cases where that meet the rule of 6, where 6 teeth in the mouth need crowns, root canals, implants, replacement with a partial. We should consider full arch. And so when you look at these 4 examples, it is full arch is perfect to treat these patients' needs and their desires. For the practice, again, by offering permanent fixed teeth in a day, you can increase your case acceptance, gain a new revenue stream for your practice, have a higher production per patient, increase your production per hour, less dental visits, and less elimination of preparative surgery, such as pre-sinus grafting. And, for example, what is my production per hour? It's probably $5,000 an hour. This was a very interesting study that I wanted to re-present to you guys. It's by Duyek et al. This was 13 patients. These were in vivo strain gauge abutments. And so this was actually in a patient mouth. And what this showed was that there was no significant difference in stress or strain between 4, 5, or 6 implants. Let me pause here and let another person in. Okay, wonderful. All right, so let's get back on it. Another amazing journal article that I think every single one of you guys needs to re-reference. I've talked about it when you took this course initially, but this is Parrell and Phillips' article, Risk Assessment for the risk assessment protocol for the immediate loaded maxilla. So what are the 5 common factors in maxillary implant failure? They found that it was opposing natural dentition, male gender, lack of bone density, the distal implant site, and parafunction. Smoking were less common in failure situations. Smoking was not more common in failure situations. So we all need to be thinking about this. We all need to be thinking about when we have failures in the maxilla, why did that occur? Most likely it's opposing a natural dentition. Most likely it's a male. And most likely the posterior distal implant site will fail. And most likely we will find that they may have some large masseters. They may grind. They may grind their teeth. And so we need to be able to look at these 5 causes of maxillary implant failure and say, geez, how can we deal with this, right? So let's just say if we have a patient, what do we do if they have a natural dentition? Do we put them in a lower denture? No. We need to augment our maxillary arch. And how can we augment our maxillary arch? Well, that would be elimination of cantilevers utilizing pterygoids. Giving these patients more implants in the proper orientation for anterior to the sinus to posterior to the sinus. So that would be number 1. The other way that we would try to mitigate this would be using longer implants, getting into cortical bone, using strong implants, and using a Morse taper connection abutment, very similar to the GM, the Neodent GM, where now we have a very good fit. It's not like the Nobel conical connection that doesn't fit as well. What do we do about male gender? I can tell you I can't do anything about that. But our guard needs to be up. And I think that for male patients, we need to augment our maxillas. How do we augment our maxillas? Well, looking at adding more implants, giving them more of a alveolectomy, getting more restorative space, giving them a stronger prosthesis, giving them pterygoids, reducing our cantilevers, reducing our stress, reducing our strain. What do we do about lack of bone density? Well, that's half the posterior maxilla. So to mitigate a lack of bone density is make sure your implants reach dense bone. So longer implants penetrate the floor of the nose, get your implant locked into cortical bone. It's the number one problem that I see with cases where there's failed implants is there is no engagement of cortical bone. The distal implant site, how do we mitigate that? Well, eliminate it by having a pterygoid behind it. And so now there is nothing distal to that other than nothing. And so now we have 0 cantilevers. You can look at Wilkerson's 2021 article, and that definitively shows that the biomechanical stress and strain on bone in a pterygoid configuration compared to a standard 4 significantly reduces the stress and strain on that distal implant site. And parafunction. Well, what we need to do in patients that have parafunction is we need to make sure that when they grind right and left, we need to make sure that we eliminate posterior excursive interferences on the molars. We typically like a group function between canines and premolars. That is great, but we do not want our molars grinding on each other in extreme lateral movements. The other thing that we need to evaluate is, do we need to consider giving them or referring them to a place that can do Botox? Typically our TMJ offices is a really good place to refer to. I don't like spending $300 per Botox bottle because we give it so infrequent. I would much rather just refer these patients to a TMJ specialist after you get them perfect. And every single one of my cases, they get a night guard. And they get a night guard that, again, has canine guidance, and we're guiding on the premolars. There is no posterior excursive interferences. So we have utilized the Dawson treatment of just anterior guidance. And, we want more than just the canines, but I am very much a fan and very much a believer in how Dawson shuts the masseter down in working excursive movements by not having posterior excursive contacts. Okay, so let's get into the nuts and the bolts. I wanted to show everybody tonight bad cases before we go into the key concepts, because this way you're not going to gloss over. So if you're a little snoozing right now, let's wake up, and this is the gold here. Okay, so this case was sent to me. I think somebody wanted to do the lower, and I think the upper was done in Mexico or somewhere. Just looking at this, I can tell that the maxillary implants are 3 millimeters to 3.5 millimeters in diameter. They're all the same size, so anytime you're placing and your posterior implants are the same size as your anterior implants, you just need to know that is a red flag and something should be off. Unless you're angling to the nasal crest, then you could maybe use similar size implants. However, all of these implants are axially, and we can definitely see here that bilaterally we have a 2-tooth cantilever, which the maximum cantilever that we have is a 1-tooth. And the other thing I want everybody to appreciate here is that the sinus extends almost to the midline. It extends at least into the lateral incisor. Let me give me a second here. We have another person to admit. Okay, wonderful. All right, back at it. Okay, so lots of problems going on. So this is how I would treat the case. And I want everybody to realize that by utilizing tilted implants, we reduce our cantilevers on the existing prosthesis. So if this was my case, we would have maybe a half a tooth cantilever by simply just distalizing and angling our middle implant. In order to do this, however, the number 13 area would need to be attempted transsinus. And in order for me to place this number 4 implant, I would have to remove this impacted tooth. And so both of those should give everyone a red flag, because trying to attempt this case, transsinus, and removing this tooth and then putting an implant next to it, is going to reduce a lot of bone in the number 4 site, and transsinus is not really as predictable It's great when it happens, and it is great because we're able to get that implant so far back and go through the sinus, but typically there is a lot less bone engaging, and so we have to nail it in order to get really good stability. So you do not want to attempt this case unless you are ready to perform zygomatics. Okay, so both of these middle implants here, the angled posterior implants, I would say in my hands, I would have roughly maybe an 80%, maybe a 70% probability that I'm going to obtain excellent stability. And so if you're going to attempt these and attempt this case, you need to be ready to utilize zygomatic implants, because I believe that this is the most likely outcome. What I view, what happened here is I think that we had an inexperienced provider attempt to, quote, standardize and do a simple all-on-X case. When you make a case become a standard, you will fail to execute. So when you deviate from the protocol, there is often a reason that you're doing so. That's why this practitioner decided to deviate from the traditional protocol, is because he knew if he performed a large alveolectomy to get good restorative space, he would eliminate most of his bone in zone 2, and he would not be able to provide a permanent fixed same-day implant bridge for this patient. And so when they deviated, that's when you run into problems. And so, just be cautious of that. If in your planning you are beginning to deviate, you need to say, I probably shouldn't. Why am I deviating? Okay, and then now what you're trying to do is make a case that should be an advanced case into a easy standard, and it's going to fail on you and fail for the patient and become a problem. And it's always much more difficult to fix these cases rather than doing them right the first time. And so, at the end of the day, there's nothing wrong with referring this to somebody or bringing someone like me into your office to do a case like this. So think of treating our patients the best, and then everything else falls in line. And again, the red flag here is when this sinus extends into the midline. Okay, here is another failing all-on-X case. So there's lots of problems here. Okay, but first let's just kind of locate the maxillary anatomy. I think we can appreciate that we don't have a lot of bone in zone 2. There's not a lot of bone underneath the sinus. There's an implant extending roughly halfway into the sinus. So we have a failed and a currently failing implant. We have a fractured temporary prosthesis. We also have lack of restorative space. So the alveolectomy was not taken all the way posterior. And if you look very closely here, we can see the abutment margin is above the free gingival margin of the tooth. So automatically, this is now a bulky prosthesis to the patient's tongue. The abutment was not placed appropriately, the alveolectomy was not done, and the implant was not placed superiorly enough. We have an implant that it extends into the sinus, and the posterior implants were not angled anteriorly. We also did not anchor these implants into cortical bone. So let's kind of go back. Let's look at luckily enough, I was sent the pre-op radiograph evaluation. So we can kind of look at this all together. So again, sinuses come very far anterior. The patient is missing both canines. But if they were there, we would know that the sinuses are touching the canines. And so that is just a massive red flag. Anytime the sinus touches the canine, it is a high probability that you'll be needing to utilize a zygomatic implant. Let's also take a step back and let's look at the patient's smile evaluation. I don't think he's really trying very hard here. I think perhaps he's going to show a little more teeth. But one of the things to note is let's look at his occlusal plane. And as we can tell, it is severely canted. We have a roller coaster going on here. And so how are we going to build this patient maxillary, beautiful all-on-X teeth when the lower teeth are garbage? You know, these cases, you know, where we get locked into what the opposing arch is. And just because we want to do an upper doesn't mean everybody can have an upper. Some patients must obtain a bijaw. The other big red flag on this case is we have a skeletal discrepancy. This is a class 3 patient. And anytime we have a large skeletal discrepancy like this, we cannot treat the upper arch alone. We have to treat both arches. Why do we have to treat both arches? Is because we're going to cheat the lower teeth back and we're going to cheat the upper teeth forward, get them back into a class 1 occlusion. And when we do that, then now we are able to achieve predictable results. So if we go back to the pre-op x-ray here, what happened? This is a male patient opposing a natural dentition with parafunction, and we have poor bone density in the distal implant site. We have 4 of the 5 risk factors in one patient. So I want everybody to appreciate that. So then how do we mitigate that? Well, let me show you what I would do. After we do our sinus mapping, we then need to appreciate that this is a difficult case. And so if you cannot do a zygomatic, this is a case where you need to bring an advanced provider in or refer to an advanced provider. Okay, because again, it's all about my job, and my goal is to encourage you guys to take on more cases and to have exceptional results and to treat our patients well and to give the best results for our patients. My goal is not for you to do every arch that walks in the door. If you are trying that, you know, and you can do zygomatics and you're very comfortable like that, then that is great. But that is not where a lot of the doctors are right now. So we need to be screening our patients better, and we need to be comfortable saying no. We're comfortable bringing somebody else in. So if I was to approach this case, this would be a PATSY protocol, hands down. We're going to do the pterygoids first. Then we're going to move to the anterior and do a nasal crest. We are going to perforate the floor of the nose. We are going to lift the floor of the nose on every patient. And we're going to penetrate into the nasal crest, into the cortical bone, and achieve excellent and very high torque values. After that, I would attempt a transsinus. That would be easy. I like to make my cases easy. The best zygoma that you have ever done is the one that you have never done. And it's just transsinus, I will tell you, is not always feasible and does not always work, especially when the sinus is very far anterior like it is on this case. However, if I am able to do a transsinus, I want everybody to appreciate that I am in the second premolar spot. That is perfect. We have a nice distribution between our implants, and we are able to going to get really good success. If we cannot achieve great torque on our transsinus implants, we need to be ready to shift and switch to the zygomatic. In my opinion, on this case, bilateral zygos is the most likely outcome on this case. So, caution to every one of you guys. I'm going to post this on YouTube so you can go back and watch it. But I want you to put this case to heart. This is not an easy or simple case. All right? And again, red flag. Anytime the sinus touches the canines, it is an advanced case. Here's another great case. Patient comes in with a chief complaint. He has 8 teeth on his maxillary prosthesis that he spent $50,000 for. He's asking for more. So what do we do in this scenario? The first thing that we need to evaluate is, do we have enough restorative space? It is likely that this patient does not have enough restorative space on the mandible. It is likely that the provider underprepared his mandible. For discussion purposes, the mandible was recommended to be left alone. However, how would we handle this maxillary case where a patient is saying, I don't want any more surgery, I just want you to give me some teeth, and I want 12 to 14 teeth? First of all, I would not do that on this case because it's going to require a 3-tooth cantilever bilaterally. This guy is a male. He meets every factor of maxillary implant loss. He meets every risk factor. One of the things, so let's kind of look at this. If I was to do this from scratch and not redo the case, but if I was to do this right the first time, we would have angled to the nasal crest, and then I would have had the posterior implants here. Okay, and as you can tell, by angling the posterior implants, we are able to get it 1 tooth more posteriorly, be able to give this guy a 10-tooth temporary and a 12-tooth final. Now, if this guy came to me and said, I just want to be fixed up, and I just want you to build some teeth, I would not do it unless we redid his surgery. We do not have to redo the upper anterior implants, assuming that the timing and the screw channels are in the right spot. However, I would recommend for this patient to receive bilateral pterygoids, have the existing posterior implants removed, so that I could go in and place anteriorly tilted long implants getting in to and perforating the floor of the nose. That would allow greater bone to implant contact. That would allow engagement of the cortical bone. That would allow for better biomechanics, and it would allow for increased AP spread. Okay, so let's look at another case from Mexico. This patient first came to me. We actually did her lower first. I don't know why we left her the way she was in the upper, but I think the lower was loose and hurting her. But as you can obviously tell, we gave her a treatment plan to, hey sweetheart, we got to give you all new upper implants. We got to give you, all new lowers. This was the upper that we did a year after we did her lower implant surgery. As you can tell, I think this was a guided case, and a practitioner can't just put these implants in. This was done flapless and it was done guided. So somebody was blind placing these implants, because this doesn't happen normally. So here she is. Here's her lower. Her entire lower prosthesis was loose, And as you can appreciate, we have massive thread loss. I think all of these implants were loose. So just terrible result, terrible failure to execute. And unfortunately, this patient had to pay twice. And so here she is, all cleaned up. I think we can appreciate, how we've, reduced all of the defects. We've given an alveolectomy down to where we have 2 millimeters of buccal bone, buccal to all of our implants. Everything is cleaned up, and as you can tell, the abutments are nice and deep, and the abutment margin is roughly a millimeter above the bone margin. And then this is a perfect way, because we will get some bone remodeling about a millimeter, and that gives us the perfect 2 millimeter biologic width after everything heals. This is her. Like I said, we did her lower first. The lower is looking beautiful. That is the nice thing about these Neodent implants, is we get great bone stability, as you can tell by the postoperative x-ray. And you can tell that we treated her maxilla. And, luckily enough for her, we were able to give her some great implants and really lock her down on a great prosthesis. Here's a case. Don't force it. Don't let your pocketbook or your eyes get ahead of what you can do. Okay? Forcing an arch to be an all-on-X standard will only result in complications for you and your patient. So when we look at this case, there is a lack of bone in zone 2 on this posterior left of the patient. And we also have multiple large cystic lesions. So this is how we treated this case. Again, this case was right before COVID, so just early 2020. And if I was to do this case today, we would have GM shorts bilaterally on the mandible, and we would have pterygoids on either side. But we had to utilize remote anchorage because we didn't have any bone in zone 2. So let me give you guys I'm going to take a quick 1-minute break, and I'll be right back, and we will talk about the key concepts of full arch implant therapy. Okay, so we're back. So, key concepts of full arch implant therapy is tilting our implants, understanding biomechanics. What dental implant system are you using? Are you using a really good system designed for full arch, that is a workhorse for full arch? Are we obtaining bicortical stabilization? What are we doing on our osteotomy to develop those? How are we getting our timing and screw channels? And what multis are we selecting? How much restorative space do we have in our alveoplasty? So this was the Misch style. Misch style was 5 in the front, and then the Nobel style, the Malo style, was 4 in the front. And as we all know, that Malo said that by tilting, we can reduce the number of implants that we need. We can reduce our cantilevers, and we get a better load distribution. It also allows for use of longer implants that increase our bone to implant contact, and we are able to go for more dense bone. A lot of the x-rays that I see, practitioners are using 11 to 13 millimeter implants, and they are missing a lot of the dense bone that they can get to with longer implants. So I want my implants to be engaged into the deep, deep mandible to where they are locked in and they are going to resist stress and strain compared to short implants of 11 and a half or 13s. Since 2019, we now adopt the zero cantilever approach with implants placed posterior to the mental foramen. So let's talk about this. So this is a revenue center for you. You are now able to elevate your all-on-X arches from 4 to 6 implants. You can charge for the extra 2 implants, and it is an extra added source of revenue. It is a much better way to treat our patients, and you are going to be able to give your patients more teeth. You don't have to have the conversation that, oh, you just need first molar. There is definitely a subset of patients that have all of their teeth. They have third molars. And so if they are going from a full complement of teeth all the way back to their third molars, here you are going to remove them all and give them first molar occlusion. They are going to ask you, hey doc, where are my back teeth? And so I encourage everybody to get in the habit and get in the use of placing posterior implants and loading them with, as long as you use Neodent. They have a Titamax. It is a 5x7. It is a very common implant that I will use back there. 5/8s. I like using a wider implant. Oftentimes, I may need to utilize a 6/0x8 or even a 7/0x8, just because there can be some instances where we, are not able to get great stability of our implants back there. Neodent also has the GM short, which comes in like a 5/0x5.5, a 5/0x7. It even comes down to a 5/0x4. I don't recommend utilizing the super short ones, the 4s, but a 5/0x5.5 is a really good implant that has allowed me to give my patients posterior support, no cantilevers, without really risking potentially injuring the nerve. And so that's the one complication, is you've got to be able to know where you are at all times, and you've got to be able to know where that nerve is. And so, if you don't feel like placing posterior retroforaminal implants, that is totally fine. But I think once you get your skills up and your confidence up and your understanding, and you understand the anatomy better, and you can reorient and relocate yourself, I think this is a really good way for you to serve your practice better and your patients better. Again, we've talked about cantilevers ad nauseum. Cantilevers magnify the force by the distance of the cantilever. So the longer the cantilever, the more force that we have on our posterior implant. So when we look at the biomechanics, okay, we've all seen this article before: 4 tilted versus 5 straight. Even though we have one less implant, we still have roughly the same forces within the system, and so the 5th implant doesn't actually do anything. We all know that. If we look at a system where we just compare 4 tilted, a system of 4 with the posterior tilted compared to a system of 4 axially, by tilting we're able to increase our AP spread, reduce our cantilever, which is the green, and that then reduces the stress and strain and the forces within the system. So by tilting our implants, we increase our AP spread, we reduce our cantilever, and we reduce the stresses and forces within the system. The other big key concept to remember is the bone zones, and the bone zones go away with your alveolectomy. So you can have a patient with a total complement of teeth and a ridiculously high lip and smile line, and that smile and the alveolectomy that you need to do can reduce all of your bone in zones 3 and 2. And so again, we need advanced techniques when we do not have bone in zones 2 and 3. We need to be able to go into zones, into the pterygoid, and then into zone 4, which is the zygomatic. So always remember that. Here is a case. We don't have a smile line here, so we can't evaluate it. But if we just look at it from, where is the bone after extraction, we can definitely see that we can get the head of our implant near the molar and into the second premolar site, which is great. And then this is an excellent candidate for pterygoids. Everybody is an excellent candidate for pterygoids. And so when we do that, we can eliminate our cantilevers, reduce our risk factors for implant loss. Here is a case. This lady barely has bone in zone 1. She was a potential quad. But when we got in there, we were able to do 2 standards and then secure a longer nasal crest. And I want everybody to look at this. That's a 13 or a 16 millimeter long nasal crest implant. And we were able to lock that deep within the patient and avoid a quad zygoma on a very very frail elderly woman. Her zygomatics were about 16 millimeters tall, and so she really did not have room for a bilateral quad. Always, always, always treat periodontitis. The way we treat periodontitis is we eliminate the teeth, we extract them all, and in a case like this, they have to get both arches done. The mouth has to be eradicated of teeth. You have to remember that. We cannot put implants into mouths with periodontitis. They will fail. And so often, your cases need to be bi-jaws. This is a updated slide from Neodent. They have a complement with 1 connection across 1, 2, 3, 4, 5, 6, 7 implants, 3.5 all the way to 7 millimeters in diameter. The standard GM helix comes in 18 to 8 millimeters, with the Titamax going down to 7, and the GM longs going to 20, 22.5, and to 25. And across that entire platform, we can utilize the GM abutments. And so it really makes abutment selection very simple. This is the GM Short, and the GM Short is an excellent implant. I hope that Neodent will adopt this thread pattern and this thread design because it is super grippy. What I really like to use, I use these in the posterior retroforaminal implant. We utilize the 5.0 by 5.5, and we are able to get incredible amounts of torque almost every time we use the GM Short. It is not recommended to load the 4 millimeter implant. It is not used for immediacy. What you need to do is place a healing abutment on the 4.0. I do find that the 5.5s work well immediately loaded. So if you use a 5.0 by 5.5, and I've been using those since they came out, and we have had very good success with the 5.0 by 5.5s. The 4.0s, I've had a few early failures on those. They're just very small, And so if I was to place those, it would not be immediately loaded. We would put a healing abutment on there, and I would actually consider placing 2 on each side if I was using a 4.0. This is the healing abutment that you put on there. I just use the one on the left. The 2.5 works well. You can use the 1.5. This is the straight abutment. It comes in different heights. It's a 0.2 versus our standard 1.5. So it is nice and short, but that is because the transmucosal component is already built in. So the transmucosal collar here is 1.3 millimeters. And so by the time we add that to our 0.2, we get our implant, we get our abutment height very similar to everything else, the 1.5. And so this has been a practice changer for me. I really enjoy it. The GM Helix as an internal hex, it's got a cone Morse connection, self-tapping, tapered implant designed for all bone types, aggressive thread design, and it's surface treated. A key concept for you to remember is that we must have 2 millimeters of bone buckled to our implant. And so how do we do that? Well, perhaps we need to do more alveolectomy to get to wider bone. Perhaps we need to choose a narrower diameter implant. And when your abutments are the same, you have no reason not to choose a narrower diameter implant, especially in the mandibular anterior. So here, I would have chosen perhaps a 3.5 by 16, 3.5, 13, maybe even a 3.75. But that would be the most that I would do. I want to choose in the maxillary and mandibular anterior, I want to choose the smallest diameter implant I can to achieve torque. So if that is a 3.5 or a 3.75, I'm going to do that all day long, because I want as much buccal bone as possible buckled to my implant to avoid this complication that you see here. Here we are looking at a panoramic image where the mandibular anterior has already had 2 millimeters of buccal bone loss bilaterally here, and this is 2 to 3 this is 6 months in. So 2 more years go by, and then the patient shows up like this with a massive growth under here. So we take an x-ray and we look, and lo and behold, that bone loss has extended all the way apically to the implant. So this is a failure scenario. Notice the remaining 6 implants all integrate. So this is not a patient-specific issue. This is a more doctor-related issue where we were burning the buccal bone with overly wide diameter mandibular anterior implants. So when we entered, this is what we found. You can see, massive defects present. So we wound up cleaning these out. Excuse me, I guess I don't have a picture of it. We cleaned out the case. We got the implants in. This is that case. We removed the 2 existing implants because they were in the way of our posteriorly tilted implants. We filled the defects with 100% autogenous bone. That was it. We just used mandibular scrapings. It was a 4-wall defect after I did the alveoplasty. And so, what Carl Misch said is that spittle grow in a 4-wall defect. And so by filling it with autogenous bone, we can appreciate on this x-ray that we already have some density and some radiopacity where the large cystic lesions were in this mandibular anterior. I also tried to choose as much virgin and native bone as possible. As you can appreciate how we went into that virgin bone between the defects. Our posterior implant stayed posterior to the defect bilaterally here. And on this implant, let's say it's like the number 23 implant, I tried to be engaging of that distal wall that did not have the defect. So the grafting was actually very it was significant. However, it was very minor, the amount of threads we had exposed prior to grafting. So when we're talking about immediate loading, and the key concepts here is that we must have a minimum of 32 Newton centimeters per implant. This is especially important. This is especially important in the maxilla. Excuse me one second. Someone just showed up. So, key concepts of immediately loading. We must have 32 Newton centimeters per implant, especially in the maxilla. The mandible, there's a different take on, there's a difference between stability versus torque. However, in the maxilla, especially in the posterior maxilla, the bone is not very dense, and it is not of substantial quality as it is in the mandibular anterior. So we want to achieve torque, but also stability. In order to do that, we need bicortical stabilization. We need to under-prep the osteotomy when needed. We want to go to dense bone placement and preference for our site selection. Got to have the proper implant selection, the proper type of implant, the proper length, and we need to have rescue implants, 5.0 and 6.0s available. Okay, so when we're prepping the osteotomy, we are paying very much attention to the quality of bone with our pilot drill. And in some instances, the 2.0 drill may be the only drill that we wind up using. So you have to understand the size of the drill and the size of the drill tips, know when to under prep, and in some cases it can be the opposite, where the bone is so dense you have to drill tap just to get your implant in, or you're going to break your driver onto your implant, and that makes for a bad day too. So there are 4 different types of quality of bone within our osteotomy, and this is a very simplistic representation. We can have all 4 bone types within one osteotomy, so we also need to know that we can have incredibly soft bone all the way for 15 millimeters of our osteotomy, and then we hit very hard D1 bone right at the base, and then we'll drill that 20 millimeters, and then we'll be able to really lock in and secure a 16 or an 18 millimeter implant into D1 bone only in the very apical portion, where the entire coronal portion or the entire coronal half, or even 2/3 of the implant could be D4 bone, but yet we're able to get great stability and great torque. So we have to know where that dense bone is, and we have to pay attention to it, and we have to prepare our osteotomies differently based on what type of bone that we're encountering and what type of bone we have within the osteotomy, and where the osteotomy is. And so when I take the implants away, we can see that the osteotomy shape changes based on bone density. So this is kind of that step back osteotomy that I really advocate for, because we're paying attention to the bone quality as we're drilling. And so very, very dense bone, D1 bone on the left, is going to look very different Then our ultra soft D4 bone on the right. One of the main key concepts that I see people miss is engagement of the cortex in the floor of the nose. And you can also do this with the external border of the mandible when needed. In order to do this, you must have an adequate implant stock on hand, because you may be planned for a 13, but then you wound up utilizing a 16 millimeter implant or even an 18 millimeter implant just to reach from the posterior to the anterior portion, penetrating that floor of the nose. And so every one of my cases, they all get a subnasal lift. And we are feeling the tip of our drill with our implants, or with my instruments. So this is a picture of where I am utilizing the drill in a periapical image to stay anterior to the sinus, but I also want to stay as close to the sinus as possible, and so here we're really hugging that sinus. And as we can appreciate, when we look right here, this is the external, this is the floor of the nose, and so I can stick a curette in, and I can feel the tip of this drill. And when I do that, I then look intraorally and find out, okay, what marking correlates to this properly placed implant? Is this a 16, or does it need to be an 18 length? And so we can always shift between whatever is needed. This is another X-ray I wanted to just show how we'll penetrate the nasal cortex here. Due to space reasons, we wound up just doing straights versus nasal crest. And this is a little slightly overextended, but because we have the subnasal mucosa lifted, it's not going to cause a bleeding issue. And that is the only way that we are able to get our implants, as we can appreciate here, into or very, very close to this nasal cortex. And so all of these implants are locked in to this nasal cortex. All of these are ultra stable, and I would say our torque values were 60 plus. And so the only way that we can overlap our implants safely and not cause major nosebleeds is because we have this membrane lifted up and we have it protected. Abutment height selection. Implants should be subcrestal, and choosing an overly tall abutment can result in flanges needed on your prosthesis, because patients don't like this metal showing, and because we have not gotten a great emergence profile. And so this was a revision case. Here we can see the flanges on the patient, and obviously we know those are non-hygienic. And when we reflect and we evaluate our tissue, we notice something very interesting here, that all of these implants have 3 to 4 millimeters of threads exposed. And so these are ailing and failing implants. So for this particular patient, she was having two of her implants in the 11 and 13 site were loose. She was having pain on this 15 implant. We elected just to not remove all of her implants. She did not want a total revision, but she wanted the right side completed. And so here you can appreciate a subcrestal placement, and I have a low abutment platform. So at the time of surgery, these are 0.75 to 1 millimeter. The margin is of the abutment is supracrestal. So our implants are subcrestal. Our abutment margin is supracrestal by about 1 millimeter, 3/4 to 1 millimeter. And again, we're going to get 1 to 3/4 millimeters of bone resorption post-surgery, and we're going to have excellent biologic width established there. So in order to make this work, though, we have to be able to thin our palate. And so when we thin our palate, we gain even more restorative space, and it makes for a highly cleansable scenario. So here is that case sutured and closed. As you can appreciate, we have very nice palatal keratinized tissue buccal to all of the 4 implants that we redid, and we can really appreciate how we do not see the abutment collars like we do on the right side. I assume this patient will want us to redo the other side here shortly, and we'll gladly do that. And as we can tell, this is the patient's delivered prosthesis. We can see that for hygienic reasons, we had to cut these flanges off. But on the patient's right side that I redid, excellent emergence profile because we got our implants subcrestal and our abutment margins were not overly tall. Other key concepts is that we need our thickness of our zirconia to be a minimum of 14 or 15 millimeters. So in addition, so where we get the 15 millimeters of restorative space required is because we have a thickness of 13 millimeters and then 2 millimeters for our biologic width and abutment. So that gives us 15 millimeters from the implant platform to the edge of the teeth. So you've got to think about where you are and where you want to go. So when this patient shows up in your chair, you don't need to be thinking about the teeth. You need to be thinking about where's the bone. And so when you combine those two together, then now you're able to know where the surgical platform needs to be from a preoperative space, all by knowing that we've got to have 15 millimeters of restorative space and emergence profile when dealing with zirconia. So a very simple rule, and this really kind of goes for molar to premolar forward. If you remove the amount of bone in the mandible on a dentate case by the width of your acrylic burr, which is roughly 6 millimeters, you are going to allow enough restorative space for your prosthesis. We obviously have to remember that we have to hide our transition line. So we cannot just reduce our alveolectomy to the smile line, but we need to go 4 millimeters beyond that, because that gives us 2 millimeters for our biologic width and our abutment, and then 2 millimeters for our implant componentry that we need in the actual transition zone. So you add those two together, you get 4. So 4 millimeters beyond the smile line is our alveolar reduction for the maxilla. So significant smile here. So we need to, if this is our smile line, we are going to reduce the alveolectomy 4 millimeters beyond the smile line. And so when we see this patient smile, as we do in this video here, okay, we can appreciate, we see a lot of tissue. And so again, so that is our smile line where you see the curette. And then where we've gone further superior, that is our alveolectomy. So that way we get the appropriate amount of emergence profile, and we are able to hide the transition zone. So please, please, please always pay attention to that when you have somebody that smiles really big, just like this. So said in another way, the smile line guides your treatment as the smile line dictates our alveolectomy. We also have to get to proper bone width. That determines our alveolectomy, and that is typically on the mandible. We have to get proper restorative space. And guess what? We have to avoid our vital structures and actually get to good bone quality. And sometimes we have to remove nasty trash bone to get to good bone quality. So, said in another way, the amount of bone that we reduce is dependent on 4 things. Did we hide the transition zone? Do we have enough width of bone for our implants? Do we have enough room for the teeth? And did we stay out of the sinus? And did we not cut into the nerve? So all of that guides us there. So again, for our zirconia, we want 12 to 13 millimeters minimum thickness of the material, plus 2 millimeters for our biologic width. So then we get to 15. Acrylic titanium, we need more space, so 15 to 16. And so when we do a bi-jaw, we need to combine those numbers together and significantly pay attention to that. There are several different methods that we can utilize to help relocate us and help us know what type of or where to make this alveolectomy. So here we're using the patient's existing partial. As you can tell, we've measured 16 millimeters, and I can make a score here on that maxillary alveolus, and then that is going to give me all of the restorative space that we need. We also must consider the anterior-posterior positioning of our prosthesis and the emergence position from our central incisors. So let's look at this case. If we look at this only from the front, it just tells us one side of the story. Here it tells me that I have done enough alveolectomy on this case. That is, 4 millimeters, from, the CEJ here, maybe 5 plus, 9. So that's getting us to, 15 millimeters of alveolectomy, which is what we want. We need to look at this case from the side. When we look at this case from the side, the restoring dentist and patient want the teeth to be relatively far anteriorly. This is, correcting some type of skeletal discrepancy here, or obtaining the proper aesthetics. If we have an underdeveloped maxilla, we can want to, bring it out to give extra lip support. So, if we just looked in the one dimension, we would have a significant ledge collecting food, causing significant discomfort. So I want everybody to appreciate the amount of ledge that is out here. This is like a diving board. And so here we have poor emergence. So this ledge is just a 90-degree cut. We're not able to give it a nice soft emergence up to the implants. So we need to further reduce this out and further give an alveolectomy, so that when we do that, we are able to generate a very nice emergence profile to reduce the ledge that was created. So when we are looking at our alveolectomy, we really need to look in 2 different dimensions. We need to look straight on, and then we need to look from the side. And so that can give us just excellent contours. And as you can see, this is that case. We have a wonderful emergence profile, and there is not a diving board anteriorly. Key concepts: neo-arch is not just 4 implants placed into the jaw. It is a system. And so you've got to treat these patients right. And just, this patient was told she was going to get Teeth in a day, she was not immediately loaded, and when she was not immediately loaded, we had massive amounts of bone resorption and bone loss that developed. And this was her prosthesis. It was a denture. I like to say that I can place implants anywhere. I cannot place implants like this. This is failure to execute, failure to load. So the patient got his implants. Looks like he got it guided. They did not achieve stability, so they left him in a denture for 2 years, and then all the bone rubbed and wore away. Again, another case here. Patient was in a denture for several years, rubbed all the bone away. So contraindications to teeth in a day: patients who have received radiation to the jaws, compromised immune systems, if they're on significant immunotherapies, if they're undergoing chemo, cancer treatments, patients on IV bisphosphonate therapy, Zometa. I won't touch a patient on Zometa, or if their A1C is above 7.5. Other key concepts is sharp drills. Get new drills all the time. Let your drills be cleaned. Put your sterile water bags in the in the refrigerator, so that when you use them, everything is cool. And using cold water helps keep things cooler. Be very organized. Have a surgical table that's over the patient, that's nice and wide. It allows for better organization, a faster surgery. Use cheek retractors, a Sweetheart, a Selden retractor. These are all the things that you need to make sure that you have. These make your assistant lives better. These make your lives better. And everybody needs to be able to utilize GM long implants. You need to be able to get to the inferior border of the mandible. On certain cases, you have hollow mandibles all the way down, and so you've got to be able to get there to give these patients permanent fixed teeth in a day. As you can see, this particular case was a very difficult case. Utilized a quad zygoma configuration, and pterygoids and zygos and posterior implants, and 2 implants didn't get stability, so we're going to lock those in later. And the entire mandible, we had to utilize 22 and 25 millimeter implants to obtain stability. So these cases happen. I keep 4 to 8 of the GM longs in stock of all sizes at every time. Pictured here, on occasion, maxillary bone can be soft, and so a 6.0 by 13 is a bailout implant. In my protocol, if a 6.0 by 13 doesn't work, then boom, we're moving to a zygo. And we had 2 here, so this was a unplanned quad again. I'm just showing you 2 unplanned quads that I've had in 2024. Both of them are right here. Very happy patients. They love their teeth. They got their permanent fixed teeth in a day. But we avoided a denture for this patient, and by utilizing remote anchorage and being able to confidently transition when needed. So this is that particular patient that I showed you guys. We utilized a scarf graft, and we wrapped it around the anterior nasal spine. Up in the anterior, we punched through the connective tissue here, and it's pedicalized. So it's attached, it's got blood flow, and this is going to lead to excellent soft tissue healing over the long term. This is a posterior GM short that I have placed. You can't really tell here, but this is very scooped out. We can see some implant threads. And guess what? We can utilize patient's bone and bone fixation screws to augment our bone grafting capabilities when needed. So always have some bone fixation pins and screws on standby. Let's talk about this. This was another cool case we got to do a couple of months ago. where the patient's right sinus, as we can see, dips beyond the proposed level of our all-on-4 shelf. Here she is smiling. And this is a combination of thick, maxillary tissue, but also posterior bone downgrowth. We did her lower arch several years ago, and before that, she was in a upper denture lower cast partial. She had combination syndrome, as you can appreciate here, where we see the posterior sinuses have dropped. And our method of treating this is to reduce this maxilla her bone was very thick buccally and actually palatally. We're utilizing copious irrigation, cold. You could use rongeurs here as well. But by trimming this on the palatal aspect, it is going to allow my flap to fit and feel and lay down very nicely.
You got it?
After we reduce this area, we are then going to score where the sinus is. Here I'm using a small round diamond, and I'm going to 360 degrees circumferentially score this, and then we will tap it in with the back end of our osteotome. The assistant is using our Selden retractor here, so we're keeping the tissue very safe. And then we're going to infracture this all in together to superiorly push and lift the sinus membrane stays intact, and then the bone goes right in. This is what we wind up with. And here she is on a postoperative x-ray, and note that the sinus is clear. And we have everything reduced. We have our all-on-4 shelf, very nice and even across from pterygoid to pterygoid all the way across the arch. This is another case that I was sent by a friend of mine. As we can tell, this is a very sad situation. This patient has gull wing lips. He is showing 10 millimeters of gingiva. And when we look at his pano, it gets even worse. So this is a very good case to remove all of the teeth, get all of the infection done. This has to be staged. Get this patient in dentures. You could do an upper denture, lower, all-on-4, all at the same time. That would be wonderful. Then you would come back once the sinuses are clear. Obviously, we have infection into the sinus. He's going to need an ENT consult, and then not proceed with bilateral sinus lift and grafting until we get approval by the ENT. So once that is lifted up, then we could proceed very carefully with arch surgery. But I want everybody to know, where do the sinuses go? The sinuses touch the canines. And so this guy is most likely going to be bilateral zygomatics. However, we have to get the sinuses lifted up here 15, 20 millimeters bilaterally, and then we can cut for days once that integrates, probably a year later. Here's a complication. This is a all-in-4 arch we did. 2 months later, the patient develops an OAC. We lay a flap, looking at a big hole, and we just take a very nice, thick palatal pedicle, and I'll suture this down deep into the vestibule, and then close it. It's going to look great. Failed implants. Here we have multiple failed implants. This is on a case I did. Had to lock into the inferior border of the mandible, leave him locked in on the 3 implants while the 4 implants heal. Always look at your patients and find out why. This was his right hand. He smokes about about 2 packs of cigarettes a day, so no wonder why we had some failed implants. Oh, this is a horrendous mess. This is one reason why we never do guided, one reason why we don't use these BioHorizons implants, because we can see multiple thread exposures. This lady had implant surgery done. Transition line over on the right is visible. I don't know where this temp is made. I don't know what this is, but she's got a terrible aesthetics, and so we had to remove all upper implants. And luckily for her, we only needed 3 advanced implants, and then we gave her 4 standards. Penetration into the floor of the nose. This is a terrible thing to do. This is why we always subnasally lift. And that is all I got for us tonight. So it's been an hour and a half to spend with you guys. And so does anybody have any thoughts or questions here? I'll open it up for some Q&A.
Hey Doc, thanks for the talk. Whenever you're dealing with a thin maxillary case, what's the thinnest width of your maxillary bone that you'll place a palatal, like a palatally placed implant before you move into a zygo?
So, good question. It depends. I would say it depends on the case. It depends on how great the zygos look, and so again, it's going to come down to predictability. It's going to come down to how thin is that palatal bone, and how tall and thin is that palatal bone. So if I'm going to wind up with, say, 10 millimeters of palatal threads exposed, I may then opt for a zygoma, just right off the bat, like not even trying that, because assuming that the zygoma is nice, easy, sinuses are clean, patient's not excessively old, that sort of thing. If, let's say, it was one of those cases where after you do your alveolectomy and it's just going to be maybe 4 to 5 millimeters of palatal thread exposed, and then we're going to have 10 millimeters 360 degrees around, really locking that in, then I would adopt, I would be more open to doing a palatal approach. As far as the thinness goes, I kind of think 4 millimeters, 4.5 is probably the limit there, because you want, where that really works really well is when you have to leave at least minimum 2 millimeters of bone buccal. So if you feel like, you're at 3 millimeters, and you're gonna cheat too far and only leave 1 millimeter of bone, that bone is gonna die. So I would opt for zygomatics. But again, the best zygoma is the one that you didn't do. So you're just always kind of weighing risk versus reward. I would much prefer to place a zygoma not in a failed scenario, right? So like if your palatal implant fails and burns all of this amazing buccal bone that maybe you could anchor your coronal aspect of your zygoma to, then that would be really nice, right? So not having a large amount of bone destruction prior to a zygomatic implant is really good. So you really have to kind of weigh what type of just shit do you want to have to deal with, longer term. So I definitely think that if you're going to be doing transsinus and you're going to be doing palatal approaches, you need to be able to do zygomatics. And if you can't do zygomatics, then I would say, well, maybe don't do transsinus or do palatal, right? Just because you have to be able to go there sometimes. So if you don't have zygomas in your toolbox, then you're going to do everything in your power not to utilize a zygomatic, and you're going to rationalize all of your clinical decisions against that. Whereas if you can do zygomatics and you feel very comfortable with that, then now you have some better decision-making skills, and you can juke and jive on a case that's like, you know what, this would be a slam dunk zygo. I'm going to be able to get buccal bone to my zygo. We're going to have great soft tissue. It's going to be highly predictable. Then I would always go that route, hands down. So just some food for you to consider. Anybody else have any questions?
Dr. Damon, great presentation. It's Alex Quante here. I just wanted to ask, on your palatal pedicle grafts, can you walk a little bit through that, how you're prepping that, and then also using your scarf grafting for soft tissue development?
Yeah, so we last week, and it's out. I don't know if you guys have listened to it, but we, Robert Stanley had some. He had a YouTube video where he said 99% of my cases don't need pterygoids, and for me, 99% of my cases should or need them, or they get them. And so I told Soren and Tyler, I said, with the Fixed Arch podcast, I said, let me interview him. I said, because we're like 180 degrees different. And Stanley is more for him. He doesn't want to take on the risk or the liability or to do that, which is totally fine. Nothing wrong with that. And if his patients need pterygoids, he refers them. Perfect. I have no qualms about that. And one of his rationales for that is, if you don't do something every day, how can you be expected to do it when you need to do it? Okay. So the learn there, right, is, Alex, how are you going to be able to scarf graft when you need to if you don't ever scarf graft? So, everyone, I want you guys to go watch, go to YouTube, go type in Texas Implant Institute. I want you guys to watch my NeoConvert webinar. It's 45 minutes, in there, I show how to thin the palate. And do that on every one of your arch cases. So when you thin the palate, that is you harvesting your scarf graft. And so if you get a lot of practice to do that well, then you will be able to do that when you need to do that. How I do it is I take we utilize long tissue forceps, and whenever I open up my palates and do my palatal reflection, I always go down to the junction of the hard palate, right? So I always go down to the horizontal portion. So my palates are flapped open bigly, as Trump would say. And so I'm able to see everything. I'm able to manipulate that tissue very well. I go ahead and trim the papilla and everything off the palate, and then I take a brand new 15 blade held in between the tissue forceps, and we cut all the way down. On the one that I showed, that scarf graft was about the size of your thumb, and we took it all the way from the posterior aspect, just call it, maybe a little bit posterior to the second molar, and we ran that all the way up anteriorly, which you saw on the zygomatic one about halfway through the presentation. That was a scarf graft that went 2 implants, right, from the posterior molar zygoma all the way to the anterior. So because I do that every day, we get pretty good at it. So I would encourage that. I'll try to put a video up maybe on Friday on how to do that. I know I've recorded it several times, but then it gets lost in the 100,000 pictures on my phone. Does that answer your question?
Yes, that's helpful. Thank you for a great presentation as well. And you said that that's on the Texas Implant Institute website.
It's on YouTube. So go to YouTube, and there's a Texas Implant Institute page, and or you can just search Neoconvert Dr. Clark Damon Texas Implant Institute. It should pull up on YouTube, but it's probably starting about 20-30 minutes in. It's after I talk about all the junk and the stuff about the Neoconvert.
Awesome. Thank you so much for a great presentation again.
Sure. Let me see. Actually, hey, Alex, don't go anywhere. Can you see? Oh, dadgummit. Let me see if I can share my screen again. I have it actually right here. Can you guys see my screen?
Yeah, we can see.
Okay. All right. So here we're trimming that buccal tissue. So there's the long tissue forceps, and I'm holding this very firmly, and I'm not holding it at the base. If I hold it at the base, it flops around. I'm going to hold it very superiorly. There is a very thick tuberosity tissue that we're taking off here. And here we're just going to bisect. And we're carrying that all the way from the posterior to the anterior. And then now the assistant is going to come in and is going to use some Adson forceps and pull that to the midline, and I am pulling to the buckle, and I am cutting, going all the way down. Cutting, going to the base. So obviously there, that was removal. If we wanted to use this as a pedicle, I would have left it attached in the posterior, and we could have rotated it around wherever we needed to. So if you can just start here and get to where you can thin your pallets, you're going to get excellent soft tissue results. You're going to get more restorative space. Maybe you guys can hear me better if I turn that volume down. Sorry about that. So again, I'm going to hold this in the more superior aspect. And I'm just taking a brand new 15 blade, and we are just bisecting this tissue. Cut, 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 cut. So if we want to pedicle this, I'll leave it attached in the posterior. So assistant's pulling to midline. I'm just taking this all the way down to the hard pallet, pulling, 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 and just trimming it off. So if I wanted to pedicle that, I would leave this area here, and then we would rotate it around wherever we need to. So. Alex, does that help you out?
That was great. Thank you.
Okay, I think that answered all your questions. Well, what do you know? I just had that up on my computer. So, anybody else have anything? If not, we'll bolt. All right, guys. Peace out. It was good talking to y'all. We'll talk to you later. Bye.